Good morning. In today's class, we are going to cover the last category of antibiotics, that is the aminoglycosides, followed by antifungal agents and antiviral agents. So we are going to study about antifungal, antiviral, and one last category of antibiotics, that is aminoglycosides. So we will first start with the aminoglycosides. Now, aminoglycosides are the antibiotic agents which are obtained from Streptomyces bacteria. All the aminoglycosides are obtained from Streptomyces bacteria except one aminoglycoside which is obtained from Micromonospora, and that aminoglycoside is gentamicin. So gentamicin is the only aminoglycoside which is obtained from another type of bacteria, which is Micromonospora. Coming to the properties of aminoglycosides. All the aminoglycosides together are bactericidal in nature. They are poorly absorbed from the GIT after oral administration. They also have poor penetration into the blood-brain barrier, and they are effective against the gram-negative bacteria. They are excreted through the urine. Now they have two important side effects, two dangerous side effects, that is ototoxicity and nephrotoxicity. Because of these two side effects, they are said to have low therapeutic index. That means they have low margin of safety because of these two side effects. These are the overall properties of aminoglycosides. Now coming to the classification of aminoglycosides. Aminoglycosides, they are classified as topical applications and systemic drugs. So in the systemic, we have an important drug, that is streptomycin, and in the topical we have neomycin. So these are the medications which are classified as systemic as well as topical. Next, coming to the mechanism of action. The mechanism of action of aminoglycoside is it inhibits the protein synthesis, or it freezes the protein synthesis. So our earlier two category of antibiotics which we had studied in the last class also had the mechanism of inhibiting the protein synthesis. They were tetracyclines and chloramphenicol. So if you remember, tetracyclines inhibited the protein synthesis by binding to the 30S subunit of the ribosomes, and chloramphenicol also inhibited the protein synthesis by binding to the 50S subunit of the ribosomes. Here the aminoglycosides also inhibit the protein synthesis by binding to the 30S as well as the 50S subunit of the ribosome. So among all the aminoglycosides, streptomycin binds to 30S subunit, whereas all other aminoglycosides bind to the 50S subunit and inhibit the protein synthesis. So as I told you earlier, the protein synthesis, it takes place in the ribosome at a mRNA complex. So this is the mRNA, and there is a site, a P site, and a E site. So in the last lecture I told you A site, P site, and E site. A site is known as the acceptor site, P site is known as the peptidyl site, and E site is known as the exit site. So at the A site, the tRNA binds, and then small aminoglycosides, they get attached. Finally, when the chain becomes long, when a mature protein is mm, what do you say, when a mature protein is synthesized, it gets dissociated or it exits from there and leads to the formation of a protein. So these medications, what do? They either bind to the 30S or they bind to the 50S and try to stop the formation of the protein synthesis. So the ultimate goal is to stop the synthesis of protein, but the mechanisms by which they act might be different. So first, the aminoglycoside, it enters into the cell membrane uh, through a passive diffusion, and it enters into the, finally it reaches the cytoplasm. Now inside the cytoplasm, it has three mechanisms by which it causes the stopping of the synthesis of protein. The first one is it interferes with the initiation complex. That means it will not allow the starting of the formation of the protein. So that is known as interference with the initiation. It basically stops the initiation of the formation of the protein, or you can say peptide formation. How does it do that? You can see over here, it goes and blocks the site where the 30S and the 50S subunit are trying to bind to each other. The next is, what does it do? It causes a misreading of the mRNA. So it gets incorporated into the 50S subunit and causes miscoding of the amino acids. That means it causes wrong coding of the amino acids so that the protein does not form. Next is, it causes premature breaking of the polysomes. So if a certain number of aminoglycosides are joining to, if a certain number of amino acids are joining together, it leads to a formation of protein. But here in the third mechanism, what does it do? It causes premature breaking of the polysomes into non-functional monosomes. So if the complete chain is not formed, if it is broken down in the middle, then also it will lead to inhibition of protein synthesis. So these are the three mechanisms by which the aminoglycoside tries to freeze the synthesis of protein. The first one is, it will interfere with the starting process, that is the initiation. Next is, it will cause miscoding of the mRNA or miscoding of the amino acid chain. The third one is, even if the chain is formed, it will cause premature breaking of the chain into non-functional chains, into small chains which are non-functional and which cannot lead to the formation of protein. So these activities are responsible for the inhibition of the protein synthesis. So it causes irreversible and lethal effect on the bacterial cell. Now this is the mechanism by which the drug is trying to kill the bacteria. But on the other side, the bacteria is also having a protective nature. The bacteria is trying to protect itself by developing different types of methods to develop the resistance. So what are the mechanisms by which the bacteria is trying to protect itself? The first one is, it is trying to modify the target site. So it is trying to modify the 30S ribosomal subunit so that the aminoglycoside does not go and bind to it. So first it is causing modification and mutation of the target site. The next is, it is causing enzymatic inactivation by producing certain enzymes which can inactivate the aminoglycoside, that is known as enzymatic inactivation. Mostly which enzyme is produced? Transferase enzyme is produced, and this enzyme tries to inactivate the drug. The third is it is causing impaired entry of the aminoglycoside into the cell. So it will cause an impaired entry. That means it will not allow the drug to enter inside the cell by showing some protective mechanisms at the cell membrane. Also, if the drug enters, it will have efflux pump. It will throw the drug out of the cell. So these are the mechanisms by which the bacteria is trying to protect itself from the drug, and this is the mechanism by which the drug is trying to attack the bacteria and kill the bacteria. Now coming to clinical uses, most of the time the aminoglycosides are combined with penicillins, and this combination is used in the treatment of endocarditis, and this endocarditis might be caused due to different type of bacteria. So in all the cases, in most of the cases, this endocarditis can be treated with the help of the combination of penicillins and aminoglycoside, whether it is caused by enterococcal bacteria or staphylococcal bacteria. Endocarditis can be treated with the help of this combination. Endocarditis, you all know, right? It is the inflammation of the heart, the inner lining of the heart, the endocardium of the heart. It gets inflamed due to bacterial infection. So this is the most important use of the aminoglycosides. Now coming to adverse effects, as I told you, it is having very narrow therapeutic index. So it is, why is it having narrow therapeutic index? Because of its adverse effects. So the two important adverse effects is ototoxicity and nephrotoxicity. So ototoxicity means damage to the ear. Now ototoxicity in turn is having two types of damages, the auditory damage and vestibular damage. In the auditory damage, the damage is to the cochlea of the ear, and in the vestibular damage, the damage is to the vestibule structure present in the inner ear. So auditory damage leads to tinnitus and hearing loss, whereas the vestibular damage, if there is the damage to the vestibule, it leads to vertigo, loss of balance and ataxia. So all these conditions are seen due to problems in the cochlea and the vestibule structures which are present inside the. If you see streptomycin and gentamicin, both of them are more vestibulotoxic. That means they cause damage to the vestibule rather than damaging the cochlea. The next adverse effect is the nephrotoxicity. Nephrotoxicity means they are causing damage to the kidneys. So the kidneys are not able to work properly, leading to rise in the creatinine levels. So creatinine is not cleared from the body, and it is leading to rise in the creatinine levels. Now neomycin, tobramycin and gentamicin are most nephrotoxic. If you compare the different aminoglycosides, Among these aminoglycosides, these three medications are more nephrotoxicity. That means they are causing increase in the levels of creatinine. Next, if aminoglycosides are given in high doses, what will happen? It will cause Curare-like effect. That means it will cause blockade of the receptor, neuromuscular junction receptors, which leads to respiratory paralysis. That is the dangerous effects if high doses of aminoglycosides are given. Now, what are the precautions that has to be taken when aminoglycoside is prescribed? So, aminoglycosides should not be given during pregnancy because it might cause risk to the fetus. It should not be given concurrently with other medications which are also having ototoxicity and nephrotoxicity as their side effects, because both the side effects might have a synergistic effect. So because of that, the drugs which may be nephrotoxic or ototoxic should not be given with aminoglycoside. Examples: the diuretic medications, minocycline, vancomycin, cyclosporin, cisplatin, all these medications are there which should not be given together with aminoglycosides. People who are already having problem with the kidneys should not be prescribed with aminoglycosides. And muscle relaxants. If the people are taking muscle relaxants, then aminoglycoside should not be prescribed, because as I told you, if high doses of aminoglycosides are given, it causes Curare-like effect. Curare-like effect means it will attack the neuromuscular junction receptors. So what will happen if the neuromuscular junction receptors are attacked? It will lead to muscle paralysis. There will be no contraction of the muscles. So you have studied this NMJ blockers, right, in your first semester. So that is the effect if high doses of aminoglycosides are given. So aminoglycosides, high doses causes muscle relaxation or muscle paralysis, and if the patient is taking another muscle relaxant, then it will have serious side effects. So these are the precautions that has to be taken, or we can say these are the interactions that can take place with aminoglycosides. So this is the last category of antibacterial agents, that is the aminoglycosides. Next, we will see about the antifungal agents. So from the name you understand that these are the medications which are used to treat the fungal infections. So before we actually start with the drugs, the antifungal drugs, we will first see what are the most common fungal infections and where do these infections attack most commonly. So fungal infections are caused by fungi which are usually present in the environment, and these infections mostly affect the superficial layers of the body such as the skin, nails and hair. So some of the common fungal infections which people might suffer are, the first one is known as the athlete's foot. So in this, the skin which is present in between the fingers, fingers of the legs, in between the toes, that skin is usually affected, which leads to blisters, and the skin is peeled off, becomes dry and cracked, and leads to itchiness at the infected site. So that is known as athlete's foot, and that is a fungal infection. Next is the nail infection. So this infection also attacks the nails, the nail of the toes or the nail of the fingers. And here what happens, the nail becomes thick, the color of the nail changes, the nail sometimes become curled, and it will become very brittle, it will break very easily. That is known as the fungal nail infection. It is also a fungal disease. Next is the ringworm infection. Now ringworm, why is it known as ringworm? Because it leads to small round shaped, ring shaped rashes on the skin of the body, and it can also affect the scalp. Vaginal thrush, it causes irritation and swelling of the vagina and the vulva. So these are the fungal infections which are attacking the superficial layers of the body. However, there are some infections which are invasive, that means they attack the inside of the body also, but such type of infections are very less and they are more serious. So if there is a systemic infection, if the fungal infection is in the organs such as brain or lungs, etc., it is less commonly seen, but if it is seen, it will be more serious. So most of the fungal infections, they can be treated with topical medications, and if the topical is not giving any effect, then systemic medications can be taken, that is the oral antifungal agents can be taken if the topical medications are not producing any effect. Apart from that, in order to control the fungal infections, good hygiene should be maintained to prevent these type of infections. So these are the most common infections that are seen. Now we will see about the different drugs and their mechanism of action. So the antifungal medications are broadly classified into 5 categories: polyenes, azoles, allyl amines, antimetabolites, and other categories include Greaseofulvin. So we are going to see one by one important drugs in each category. Coming to the first one, that is Amphotericine B. So we will see how this drug is acting. The most important thing which you have to remember is these drugs, these medications, they basically attack the ergosterol of the fungi, ergosterol. So they are attacking the synthesis of ergosterol. Inhibitor of ergosterol interacts with ergosterol. Now what is ergosterol? Why are the drugs going and attacking the ergosterol? Ergosterol is a, a, a component which is very importantly present in the fungal cell membrane. So this ergosterol helps in maintaining the fungus, actually you can say the cell membrane consists of ergosterol, and this ergosterol helps to maintain the activity of the cell membrane, the permeability of cell membrane, and it carries out different functions of the cell membrane. However, the synthesis of ergosterol is not a one-step process. It is a complex process, and it involves different enzymes and different steps to lead to the formation of ergosterol. So these drugs are attacking the ergosterol. They are trying to inhibit the synthesis of ergosterol by attacking different enzymes. As I told you, the synthesis of ergosterol is a complex process. It involves different steps, and each step has the use, or each step involves the use of different enzymes. So at each step, if the enzyme is inhibited, the further steps will be nullified. So for example, if we are saying azoles, so azoles are cotrimazole, fluconazole, itraconazole. So it is having zoles at the last name. So these azoles, they are inhibiting the ergosterol biosynthesis, but they are attacking which enzyme? Cytochrome P450. Similarly, allyl amines, they are also inhibiting the ergosterol synthesis, but they are attacking another enzyme. Which enzyme? Squalene epoxidase. So azoles and allyl amines, both of them, they are inhibiting the synthesis of ergosterol, but they are attacking different enzymes. Whereas the first category, that is polyenes, they, what do? They interact with the ergosterol and they form channels through which small molecules leak out of the fungi. So these drugs, that is the Amphotericine B and the Nystatin, they are basically rupturing the cell membrane of the fungi by interacting with the ergosterol. So ergosterol is the main component which maintains the cell membrane of the fungi. So these drugs, they are attacking the ergosterol and they are causing small holes in the cell membrane. Now when the cell membrane is ruptured, all the materials which are present inside the cell, they leak out, ultimately leading to cell death. So see, if you can see in this picture, yeah. Amphotericin B interacts with ergosterol, forming pores. So it is interacting with ergosterol and it is forming pores like this. Okay, so not only one, many different pores will be formed. So once there is an opening, what will happen? The small molecules and all the things which are present inside the fungal cell membrane, it leaks outside, leading to cell death. So everything is lost from inside the cell, everything is slowly moving out of the cell, ultimately it will lead to death of the cell. Now this amphotericin B is used against different type of fungal infection. It has poor cerebrospinal fluid penetration. It can be administered topically and by intravenous route, and it is used against different candidiasis, different what do you say, oral, vaginal or cutaneous candidiasis, and different mycosis, that is whether it is mycosis are also fungal infections, candidiasis is also fungal infections. So mycosis might be superficial, subcutaneous or systemic. So systemic mycosis, especially in systemic mycosis, amphotericin B is considered as the gold standard. That means it can be prescribed for systemic cases of mycosis. Now these amphotericin B are later replaced, I mean the polyenes category of antifungal drugs are later replaced by the azoles. However, it is effective in the cases of leishmaniasis and in resistant cases of Kala Azar. Kala Azar is, it is also known as black fever. It leads to fever and attacks the spleen and the liver. So the spleen and the liver will be damaged in the Kala Azar. So the fungi, when it attacks the spleen and the liver, it damages it. So in such cases, amphotericin B can be prescribed. Next is the adverse effects. So the toxicity is high. That is why these polyenes are replaced by the azoles because of high toxicity. Now, once the drug is administered, it will lead to fever, ache, chills, nausea, vomiting, etc. And if it is given for a long term, then it will cause nephrotoxicity and bone marrow depression. So because of these side effects, what is done? These drugs are now replaced by the second category of medications, that is the azoles. Next is the nystatin. Nystatin also belongs to the polyenes, the first category, and it is a topical medication. It is not absorbed orally. So it can be used in different oral conditions such as oral thrush, denture stomatitis, and antibiotic associated stomatitis, oral candidiasis of the lips, etc. So all these conditions, it is used topically for the treatment of especially fungal infections of the mouth. Next is the second category, that is azoles. In that we have ketoconazole, cotrimazole, itraconazole, etc. So all these are the belonging to the category of azoles. So ketoconazole can be used orally as well as topically, and it is used to treat fungal infections when other treatments have failed, or if other treatments are contraindicated, then ketoconazole is prescribed. However, when this drug is prescribed, hepatic and liver function tests should be monitored because it has adverse effects. It causes nephrotoxicity, sorry, not nephrotoxicity, it causes toxicity to the liver. So these liver function tests should be continuously monitored. So 1 in 1500 patient might develop hepatitis. So that is why ketoconazole, when it is prescribed, then the liver function test should be monitored because it has dangerous effects on the liver. Next is cotrimazole. Cotrimazole is also prescribed when other medications are not working, especially it has replaced amphotericin B. Because of the adverse effects of amphotericin B, now cotrimazole is used for systemic mycosis, and it is also used topically. It is usually prescribed for fungal infections of the genital regions, that is vaginitis, and it is also prescribed for leukorrhea, that is also an infection, genital infection, which attacks the vagina, and azoles should be avoided during pregnancy and lactation. Next is 5-fluorocytosine. Now this 5-fluorocytosine belongs to another category of antifungal agents, and it basically acts by inhibiting the DNA and RNA synthesis. It belongs to the anti-metabolite category, and it acts by inhibiting the DNA and RNA. It is always used in combination with amphotericin B, and it is very less used alone, seldom used alone. And why is it used in combination? For which conditions it is used? It is used for meningitis. With amphotericin B, when it is combined, it is the drug of choice for treating meningitis. Next is the Greaseofulvin. Greaseofulvin belongs to another category of antifungal agents. It belongs to the other category, and it is also a drug of choice, especially for the nail infections, which is caused by Trichophyton rubrum. That is also a fungal infection, and it can be administered orally. And this drug, it inhibits the multiplication of the fungi by inhibiting the mitosis step. in the cell cycle of the fungi. So this is how the antifungal agents are acting. So we have seen about the important infections of the antifungal agent, important fungal infections. Then we have seen about the classification and the mechanism of action, how these drugs are inhibiting the ergosterol, and what is the importance of ergosterol, and which category of medications are inhibiting which enzyme, and ultimately leading to the inhibition of ergosterol. Next, we have seen about the individual category of drugs, that is Amphotericine B. Its mechanism is different when compared to the other category of antifungal agents. Then we have seen the adverse effects, Nystatin. In the azoles category, we have seen ketoconazole and cotrimazole. Then 5-fluorocytosine is in the other category, that is the anti-metabolites. And then we have seen Greaseofulvin, its mechanism of action and its uses. So each category of drug has a mechanism of action and its use. So this is about the aminoglycosides and the antifungal drugs. Next, we are going to see about the antiviral agents.